It's time for another warm-up. Let's get going. Which organism produces an exotoxin that works via each of the following mechanisms? So first one, we have inactivates EF2. So this one is going to be Corynebacterium diphtheriae, also Pseudomonas exotoxin A. Next, we have activates GS. So this is going to be Vibrio cholera, but also think about that ETEC, heat labile toxin. Disables GI. So this is going to be pertussis toxin. Bacterial adenylate cyclase. This is going to be Bacillus anthracis. Blocks GABA and glycine. This one is Clostridium tetani, causing lockjaw. Next question, what drug is used to help make the diagnosis of myasthenia gravis? Well, the actual answer is edrophonium. Now, the brand name is Tinsulin, so sometimes we call this the Tinsulin test. It's too short-acting to be used to treat myasthenia, but it's used to make the diagnosis. Next, which heart sound is associated with dilated congestive heart failure? So think about the dilated ventricle. It's going to be that S3 heart sound. Now, which heart sound is associated with chronic hypertension and maybe a more stiffened left ventricle? That's going to be an S4 heart sound. All right, that brings us to the end of the warm-up. I'll see you next time.
We've just been talking about B cells and antibodies, and in this video, we're going to talk about two issues that are related to antibodies, including immunization and autoantibodies. We've briefly mentioned passive and active immunity. Passive immunity is where you give someone preformed antibodies that were made outside the body to enhance their immune system for a short period of time. And obviously, this provides immediate immunity. An example of this is IgA in breast milk. The IgA in breast milk provides a certain amount of passive immunity against specific pathogens. Another example is rabies. If you get bitten by a rabid dog or skunk or whatever, you can get a series of rabies immunoglobulin shots so that you don't get infected. But these antibodies have a short half-life, around 21 days. That doesn't mean that all the antibodies are going to be gone in 3 weeks. It just means half of them are going to be gone in 3 weeks. So, for the most part, if you give immunoglobulins to provide passive immunity over an extended period of time, you have to dose it around once a month. Active immunity, on the other hand, actually involves exposure to foreign antigens, either because the patient had a previous infection or maybe they were vaccinated against something. You know how vaccines work. You give a killed virus or an inactivated virus or bacterial antigen, like a polysaccharide from a capsule, and you inject that so that the patient's immune system can activate some B cells and some T cells against it and be ready, just in case they ever come in contact with the active pathogen. And instead of providing immediate immunity, active immunity takes a few weeks to develop. With that first exposure, in addition to ramping up the production of T cells to fight the infection and ramping up B cells and the plasma cells to produce IgM and eventually IgG against the pathogen, you're also generating memory T cells and memory B cells, which can stick around for long periods of time, providing active immunity. So most of the immunizations that we routinely give, such as tetanus, influenza, MMR, and pneumococcus, those are all examples of active immunizations. Now, if you have a patient who is exposed to rabies, we give both the rabies immunoglobulin and the rabies vaccine, both passive and active immunity. Or if someone comes in with a wound that is high risk for tetanus, we sometimes give both tetanus immunoglobulin and the tetanus vaccine at the same time. Let's talk about vaccines in a little more detail. We're going to start with vaccines against viruses. As I mentioned, there are different types of viral vaccines, live vaccines and inactivated or killed vaccines. With a live vaccine, you actually give the patient the infection, but it's a very weak, attenuated form of the infection. You're allowing that weakened virus to infect cells so that those cells can present the viral antigens to cytotoxic T cells. So live vaccines lead to cellular immunity. Those cytotoxic T cells will not only kill off the infected cells, but some of those activated T cells will become memory cytotoxic T cells, which go dormant and wait for the next time that virus shows up. That's what provides long-term, maybe even lifelong, immunity. A student sent us a mnemonic from the most common live attenuated virus vaccines. The mnemonic is, attention, please vaccinate young infants with MMR regularly. Attention is to remember that this mnemonic is for live attenuated virus vaccines. The P in please is for the Sabin polio vaccine, which is the oral polio vaccine. The V is for varicella, also known as chickenpox, and the Y is for yellow fever. The I in infants is for intranasal influenza vaccine, infant intranasal influenza, although this was recently taken off the market. MMR is for MMR, measles, mumps, and rubella, and the R in regularly is for rotavirus. Now, because you are actually giving live virus, generally you don't give live viruses to immunocompromised patients. Or if you have a patient that's around immunocompromised individuals, you might not want to give them the live vaccine either, because you don't want to expose the immunocompromised person that they're around. There are some notable exceptions to this rule. MMR and the varicella vaccine and yellow fever vaccine can be given to HIV patients as long as their CD4 is above 200. Remember, just because the patient has HIV doesn't mean the patient is immunocompromised. Yet, if the CD4 count is above 200, you give the vaccine because the benefits outweigh the risks. Measles cause about 40% mortality rate in HIV patients. So as long as the CD4 count is above 200, give those live vaccines. Those are the live virus vaccines. Now let's talk about inactivated or killed virus vaccines. Here, the virus can't infect the host cell, so there's no cell-mediated immunity. You're just putting antigen into the system so it can be recognized by the antibodies on the surface of B cells, and that will eventually produce antibodies against the virus. So that's humoral immunity. And these non-infectious vaccines can also produce the production of memory helper T cells. But one issue with these inactivated virus vaccines is that in some cases the immunity can wear off, so a booster dose might be needed. So killed virus vaccines include the intramuscular influenza vaccine, hepatitis A vaccine, the rabies vaccine, and the Salk polio vaccine, which is not the oral polio vaccine, but the injected polio vaccine. I also want you to know which vaccines are egg-based vaccines. The influenza vaccine and the yellow fever vaccine both use viruses grown inside of eggs. So if you have a patient with a severe anaphylactic egg allergy, they need to be skin tested before giving one of these egg-based vaccines. The MMR vaccine is also egg-based, but it's such a tiny, tiny amount of egg, you don't really need to worry about it. So those are the viral vaccines. Bacterial vaccines tend to be either vaccines against the bacterial toxins, like the tetanus toxoid, or the polysaccharides on the capsule of strep pneumo or H. flu. Or sometimes we actually give killed bacteria, like Vibrio cholera, or other attenuated bacteria like the typhoid vaccine or the BCG vaccine against tuberculosis. But in all of those cases, because the bacteria aren't actually infecting individual cells, there won't be a cellular cytotoxic T cell response. So bacterial vaccines are generally going to induce a humoral B cell response. One of the other things to consider with bacterial vaccines that use toxins or capsular antigens is whether or not the antigens have a peptide component. Peptide antigens, or protein antigens, are called thymus-dependent antigens. Thymus-dependent antigens are antigens that can be presented on the major histocompatibility complex. MHC molecules present peptides, which means the thymus can present that antigen to T cells during selection. This means that when we are exposed to a pathogen, we have helper T cells that are able to mount an immune response to generate IL-4 and IL-5, and that will activate B cells, and that promotes antibody class switching from IgM to the more abundant IgG. So peptide antigens, or thymus-dependent antigens, induce a better immune response and a better immunologic memory. When thymus-independent antigens are non-peptide antigens, which means they cannot be presented to the T cells in the thymus, it also means there will be no T cell response, and the B cell response is weaker, because again, the helper T cells are important for activating B cells. So with thymus-independent antigens, the immunological memory is weaker, and boosters are commonly needed. One good example of an antigen that can't be presented to T cells is a lipopolysaccharide, which is the endotoxin found on gram-negative bacteria. So sometimes when we design a vaccine against encapsulated bacteria, we don't give the lipopolysaccharide component. We conjugate that lipopolysaccharide into a peptide, which helps induce a longer-lasting immune response. Now we're going to talk about autoantibodies, which is when your immune system turns to the dark side and starts making antibodies against your own normal antigens in your own tissue. In the study guide, there's a huge table listing autoantibodies that are high yield for step 1. This is at least a 4-star topic. So as we go through each of these, I want you to write down the disease associated with the antibody. I've kind of grouped them by organ system, which may help you keep them straight in your mind. The first one is antibodies against IgG. This is also called rheumatoid factor, which is associated with rheumatoid arthritis. The next one is anti-citrullinated protein antibody, ACPA, which is a little more specific for rheumatoid arthritis. ANA, or anti-nuclear antibody, is a classic autoantibody for lupus, but remember, this is fairly nonspecific. Anti-Smith antibodies are also seen in lupus, and they are much more specific for lupus. And anti-double-stranded DNA antibodies. These are especially associated with lupus renal disease. Antihistone antibodies should make you think about drug-induced lupus. About 50% of people with systemic lupus will be positive for antihistone antibodies, but 90% of patients with drug-induced lupus will be positive. And remember, the mnemonic for drugs that typically cause drug-induced lupus is SHIP. You can go back to rheumatology if you need to revisit that one. Anticardiolipin antibodies and antiphospholipid antibodies are both associated primarily with lupus, especially patients with hypercoagulability and thrombus. We'll come back to that in a moment. Anti-centromere antibodies are seen in crest scleroderma. So the C in centromere, C for crest scleroderma. Anti-SCL70 is pretty easy. That's because SCL stands for scleroderma, diffuse scleroderma. The other name for this is anti-DNA topoisomerase. Anti-Jo1 is seen with polymyositis and dermatomyositis. Anti-SSA and anti-SSB. Remember, SS is for Sjogren's syndrome, SSA is anti-Ro, and SSB is anti-LA. There's an antibody called anti-U1-RNP, ribonucleoprotein, which is seen in mixed connective tissue disease. And the next one is from dermatology, which is anti-desmoglein, seen in pemphigus vulgaris. Now, if you have an anti-acetylcholine receptor antibody, what disease is that? That's myasthenia gravis. Then we have a couple of GI diseases. Anti-endomysial or anti-tissue transglutaminase antibodies and also anti-gliadin antibodies are associated with celiac disease, where you have a gluten intolerance, and that leads to blunting of the microvilli on your enterocytes and malabsorption. Anti-mitochondrial antibodies are seen in primary biliary cholangitis, and anti-smooth muscle antibodies are seen in autoimmune hepatitis. In the endocrine system, anti-glutamate decarboxylase antibodies are sometimes seen with type 1 diabetes. Anti-thyrotropin receptor antibodies are seen in Graves' disease. These are antibodies that bind to TSH receptors and stimulate the thyroid gland to start releasing too much thyroid hormone. Anti-thyroid peroxidase, or anti-TPO antibodies, are primarily seen in Hashimoto thyroiditis. There are also anti-thyroglobulin antibodies that are seen in Hashimoto's thyroiditis or Graves' disease. So there's a lot of overlap in the thyroid antibodies. And then a few autoantibodies that we see in certain kidney diseases. Anti-basement membrane antibodies are seen with Goodpasture syndrome, and that can affect both the kidneys and the lungs. C-ANCA is seen with granulomatosis with polyangiitis, or the older name for this was Wegener's granulomatosis. This can also affect both the kidneys and the lungs. So link those two together in your mind. If you see kidney disease plus lung disease, think about Goodpasture syndrome and granulomatosis with polyangiitis. And then there's p-ANCA antibodies, and these are seen with the type of glomerulonephritis called pauci-immune crescentic glomerulonephritis, and also Chug-Strauss syndrome, and a type of vasculitis called microscopic polyangiitis. I want to circle back and talk about antiphospholipid syndrome, which can get a little confusing, so don't get too hung up in the details. Cardiolipin is a component found in the inner mitochondrial membrane, and for whatever reason, individuals with anti-cardiolipin antibodies are prone to thrombosis and excessive blood clotting. There's another substance called beta-2 glycoprotein, which is a glycoprotein that binds to cardiolipin in vivo. And anti-beta-2 glycoprotein antibodies will also cause thrombosis and clotting. Both of these autoantibodies are sometimes lumped together as antiphospholipid antibodies. Or, if you have blood clots and if you start testing positive for this, we might say that you had antiphospholipid syndrome. Since all of these antiphospholipid antibodies are frequently seen in lupus patients, this is sometimes called lupus anticoagulant, because these patients will have a prolonged PTT, partial thromboplastin time. So based on the labs, they look like they are anticoagulated. But again, these antibodies are actually prothrombotic, and they are not anticoagulants at all. Confused yet? Me too. Here's the bottom line. All of these terms, anti-cardiolipin antibodies, anti-beta-2 glycoprotein antibodies, antiphospholipid antibodies, and lupus anticoagulant, they all refer to the same group of antibodies. You don't need to worry about the subtle differences between them for step 1. Just recognize they all go together and they're associated with lupus and other autoimmune diseases. They can cause recurrent arterial and venous thrombosis, even in fairly young patients. They can also lead to spontaneous abortions, like miscarriages, because of thrombosis. And for some reason, they give you a false positive RPR or VDRL, which is your test for syphilis. So again, don't worry about the details, just know the associations and you should be in good shape. Let's finish up by talking briefly about amyloidosis, which is basically where you have accumulated too much of a specific type of protein in the tissues. That could be accumulation of immunoglobulin, which is why we're going to talk about it here, or it could be another type of protein. As that excess protein is deposited into the tissue, it starts to form beta-pleated sheets, and the tissues start getting thicker and bulkier, and all that bulk can interfere with the normal function of the tissue. So if you had cardiac amyloidosis, that might cause thickening of the heart muscle and CHF, or it might interrupt the conduction system and cause arrhythmias. Or if you had renal amyloidosis, that might cause nephrotic syndrome and renal failure. Or deposition of amyloid in the walls of the blood vessel, that can lead to strokes and heart attacks. So there are a lot of different clinical presentations. Let's look at some different types of proteins that can cause amyloidosis. This isn't very high yield, but it is fair game. There's immunologic amyloidosis, which can be seen in multiple myeloma, which is where you have proliferation of the plasma cells that are making way too much immunoglobulin. That's specifically the antibody light chains that cause problems. They coalesce to form AL proteins. AL is for amyloid light chains. This is also called primary amyloidosis. Then, secondary amyloidosis occurs when you have chronic inflammation, and that leads to an accumulation of an excessive amount of acute phase reactant known as serum amyloid-associated protein. So if you have a chronic inflammatory disease, like rheumatoid arthritis, you have too much of this serum amyloid-associated protein, and that can form these AA protein molecules that then form amyloid. You can have excessive amylin, which is a minor hormone secreted by the pancreas along with insulin. And in the cases of type 2 diabetes, where there is insulin resistance and the pancreas is working overtime to make extra insulin, it's also going to make extra amylin, and that's going to form AIAPP protein, and that's going to cause amyloidosis. If you have a medullary carcinoma of the thyroid where there's too much calcitonin produced, that excess calcitonin can form ACAL protein, which can cause amyloidosis. In Alzheimer's disease, there's something called amyloid precursor protein, or APP, that is cleaved to form beta amyloid, or A-beta, which builds up in the brain. So, in a way, Alzheimer's disease is amyloidosis of the brain. It's not diffuse multi-organ amyloid, just discrete plaques of this A-beta protein in the brain. And there's dialysis-associated amyloidosis, which is where a protein called beta-2 microglobulin builds up. So be aware of these different amyloidoses. Not incredibly high yield, but definitely fair game and possibly worth knowing. One thing that's definitely worth knowing is how to diagnose amyloidosis based on a biopsy. You need to know that you use a Congo red stain, and that will cause the amyloid protein to light up bright green under the polarized light. You might see it described as apple green birefringence. Now, it's time for the end of session quiz. Let's get started. First question. Which viral vaccines are potentially dangerous to give to patients with an egg allergy? That would be influenza and yellow fever. Next question. Which autoimmune disease is associated with anti-dsDNA antibodies? That would be lupus, systemic lupus erythematosus. Which stain is used to identify amyloid microscopically, and how is this appearance described? It's the Congo red stain, and the amyloid protein shows apple green birefringence under polarized light. That's it for now. We'll see you next time.